Let's get going. We finished off last time, a couple of weeks ago, on the vestibulocochlear nerve, which is number 8. We're going to go hopefully 9 and 10 today, get those done. We didn't quite finish off the vestibulocochlear. I just wanted to go over some of the testing for that. We did the video was quite short because there's not much to see. Basically comes straight off of the brainstem and then into its little hole in the skull, and then it goes into the ear. You can't really see where it goes because it's within the bone. Because there was nothing on the face, like obviously the facial and trigeminal and into the eyes for all the other ones, that it literally just goes into the bone, like literally in between the kind of edges of the bone as well. You can't really see much. Let's just have a bit of a recap on that. There were 2 branches of the vestibulocochlear. You've got the vestibular branch, which is to do with balance and proprioception, and then you've got the cochlear branch, which is to do with hearing. These 2 branches just here. The cochlear is like a snail-shaped bone, picks up vibration, and that vibration is then turned into a signal, okay, so a nervous system signal, and then directly into the brain so that your brain can interpret the sound. And then the vestibular system is to do with the semicircular canals, balance, and being able to work out where you are in space, basically. That's what that does. I think we started to go over this, and then there was another slide that was really heavy. I kind of left it. So I'm going to delve into that slide today. The vestibulocochlear basically means, small cavity snail, basically. So sensory mainly, 2 branches, so vestibular for equilibrium, proprioception, balance, and then cochlear for hearing. There are small motor branches as well that innervate the hairs in the inner ear. That's why I say it's mainly a sensory nerve, but there are some motor aspects to it as well. Vestibular lesions, so problems with the vestibular part, can lead to things like vertigo, ataxia, which is an altered gait, and nystagmus. We've seen that before, where the eyeball rapidly moves from side to side. It's usually a side-to-side motion. And then cochlear lesions, the list isn't obviously exhaustive, but you can have things like tinnitus and can be affected by trauma or infection as well. A couple of different reasons why you might have a problem in that region. I think we finished up here. You can see the different structures that the vestibulocochlear nerve innervates or receives sensory information from. And then this was the heavy slide. I just wanted to go into a little bit of detail here, not too crazy. But basically the way we hear is partly conductive through the bones and partly sensory neural. You've got the sound waves coming in, hitting a bone and causing a vibration. That's the first bit. And then that vibration of the bones is then interpreted into the sensory neural part, transmitted to the brain. It's kind of like changing sound waves into nerve impulses. That's basically what the system does. If there's a problem with the sensory neural part, which is in the inner ear, the ear can receive sound waves through the outer and the middle ear. It's able to receive the signals, but it's not able to send the data from those sound waves to the brain, and therefore can't be interpreted by the brain. Sounds going on around you, and it's happening as normal, but and there's no problem with the outside of the ear. But as it gets into the sensory neural part, it's not then able to transmit or change that signal from bone into sensory neural. For example, the cochlear branch of the vestibulocochlear nerve is injured, the nerve itself is injured, or there's an infection which is affecting the nerve. Something's happened to the nerve. So sounds will therefore be quieter on the affected side, okay, because you may still be able to sense something, but you can't hear it very well. These tests are they're not really black and white. This is usual. You'll see in a second on one of the papers that I found about these, sensitivity of this test is not very good. Conduction loss affects the middle or outer ear. Basically, your ear is blocked. If you've got an ear full of earwax, it's not the nerve that's the problem. Basically, the sound waves aren't able to get there. Morning, and very apt as I'm just back from having my hearing aid fitted. Perfect. Very good. Yeah, you can definitely relate, Penny. Conduction loss, bone conduction loss, is in the middle or outer ear. The ear is blocked due to abnormal bone growth or inflammation, fluid, or basically gunk. If you've got gunk in your ear, or there's loads of fluid in there, or it's kind of like cauliflower ear, you're not going to be able to hear because you can't get the sounds into your lug hole, basically. Bone conduction, vibration on the skull, will be increased if the middle or outer ear is affected. The theory is there's an upregulation of the inner ear, which is making any kind of sensation around that it's receiving through the bone heightened. It's more sensitive to bone conduction. So it's amazing what the body does, and it's weird, isn't it, that if your ear's blocked, it actually may make that bone conduction more sensitive. There is a test that you can do. It's called the Rin and Weber test. We've got the Rin test, which is a bone conduction test. What you do is you bang a tuning fork and you place it against the mastoid, which is just behind the ear. That's testing bone conduction and whether you can hear it traveling through your ear. And then when you can't hear that bone conduction anymore, you then take the tuning fork off, you turn it around, you've got the prongs near the ear, and then can you hear the air conduction? You're trying to see the difference between bone conduction coming through and air conduction. And the good thing is you don't have to remember what's what because there's a table. And then the Weber test is a tuning fork placed in the center of the head. Some people place it on the forehead. Some people place it on the top of the head, so you look a bit like a Teletubby. But yeah, most of the time, well, when we were taught it on the top of the head. But for me, it makes sense on the forehead because obviously with different thickness of hair, that kind of thing, you may affect the test. If you have a look here, the sensitivity isn't great with these tests, so 43 to 91%. So yeah, it's not ideal. You can have some false positives, false negatives. If we have a look here, this is the table that you can use for the Rin test, where you place the tuning fork on your mastoid and then switch it to your ear. I'll show you a little video in a sec. Normal air conduction should be higher than bone conduction. So you place it on the mastoid, the vibrations run out and you can't hear it anymore. You turn it around so the forks are near the ear and you can still hear a buzzing. That's normal. That's what should happen. Okay. With conductive hearing loss, the bone conduction will be greater than the air conduction. But if it's a sensory neural hearing loss, remember that's ramped up. So the air conduction is greater than the bone conduction. We get a false positive, which is a bit confusing. It looks normal, but actually there may be a problem. What you do is you combine it with this test and you place you bang the tuning fork, place it on the forehead or the middle of the head, whichever is appropriate, and it should be heard equally in both ears. If there's conductive hearing loss, then you'll hear it more in the bad ear. And if there's sensory neural hearing loss, you'll hear it more in the good ear. So if you're getting air conduction greater than bone conduction, which is normal, but you're hearing it louder in the good ear, then it could be that there's sensory neural hearing loss. That's why this chart is really useful. So what the hell does all that mean? Let me show you this. Just get down to those videos. This is the Rin test in a second. Just gear this one up. Here we go. This is from Geeky Medics, I think. Really good YouTube channel. Doing a hearing assessment with the Rin and Weber test. Obviously, introduction, first of all, they're very good at this kind of thing, doing things by the book and as you should. Confirming the patient's detail, making sure you know who you're speaking to. Explain what you're going to do, exactly what it's for, so that you can get informed consent. Go through all that process. And then they carry out a basic hearing assessment. You can do just a block off one ear and then you speak some numbers or make a sound, like rub the fingers. Can you hear the sound? And then you're testing each side. And they should be able to hear in both. And then this is the test. This is Weber's test. It's obviously explaining what it's going to do. Dink on the tuning fork on the forehead, and you should hear that equally in both ears. If it's less on one side, more on the other, then there may be an issue. And then the rinse test, again, you bang the tuning fork, placed it on the mastoid just behind the ear, ask them if they can hear it, and then when it stops, get them to let you know, and then you switch it to their ears, and they should still be able to hear that. The tuning fork that you use is usually a 512 hertz. That's what's used on that test. But that is the test, or one of the tests, for the vestibulocochlear nerve. Obviously, that's the cochlear part. We've also got just go to this video. We've got the vestibular part as well. And this is the assessment for vestibular nerve. It's a walking assessment, basically. Can they walk toe to toe or heel to toe? Do they have a loss of balance? So you can do tandem walking, and then you can do something called a Romberg's test, okay? And you can change the position of their feet. And we always used to get told off for this, if I just take that back there. If someone was pretty vulnerable and was moving around all over the place and a bit wobbly, or you suspected that there might be, that is the last place that I would want to put my hands, just in case they fell forward. So what we used to do was place the forearm up against the upper chest. Just a bit of hand placement there. You show them that you're going to be there, because especially if they feel dizzy anyway, you hold in that position, and then if they fall a little bit, then obviously they can open their eyes, but you're going to be there to catch them as well. So this is Romberg's test. And then you're just checking for any kind of sway when they close their eyes. Is that the same one? Oh yeah, I've done the same on that video. Oh, I've done all of them together there. Okay, cool. So those are the tests. So you've got behind the ear, into the mastoid process into the ear, then on the head to see whether it's the same each side. So that's the cochlear part of the vestibulocochlear nerve, and then the vestibular part is a balance test, and you can use tandem walking and the Romberg's test, where they close their eyes and they have their feet in different positions. Okay, having done these tests, people get really, really worried about falling over, obviously, and quite often they've fallen over previously, so they're a bit scared about it. So yeah, always make sure that you reassure, and if you haven't got a clue what you're doing on these tests, then refer them to someone else. That's always the best. Yeah, so there's your Rin and Weber test, there's your Romberg test. Okay, cool. So that was vestibulocochlear. So from a couple of weeks ago, we learned about where it goes and what it does, and this week how to test it. Now we are moving into our last few. So we've got 4 nerves left, 9, 10, 11 and 12. Going to hopefully get through 9 and 10 today, should do. And then we've got our last session on the cranial nerves next week. So this is the number 9 is the glossopharyngeal nerve, and we've mentioned these words before. So the glossus, which is to do with the tongue, and then the pharynx at the back of the throat. So it's going to be something to do with this region here. The name just kind of gives it away. And if we go back to the original summary table, we've got the nerve name is glossopharyngeal, so that begins with G, so that's the green on the mnemonic as you go through. And then is it sensory, motor or both? Well, if you have a look down here, this is the mnemonic. So some say money matters, but my brother says big, so because it's big there. So this is the 1, 2, 3, 4, 5, 6, 7, 8, 9th nerve, big there. This is both. We've got some sensory components, we've got some motor components, and there are also some parasympathetic elements to it too, okay, which are special visceral sensory, special visceral motor, okay. So we've got things under our conscious control, and we've got things happening that we've got no control of with this particular nerve. So what does it do? It provides taste, okay, and also helps with swallowing because it activates the pharynx muscles. So the tests that you can do, and we'll have a look at these a little bit later on. There's a really horrible test. It just makes me feel a bit sick just even thinking about this. But you can do a gag reflex test where you get those tongue depressors that they use in the doctors, and they make you say ah, and you push the tongue depressor down and then use another tongue depressor to kind of prod the back of the throat. Just the thought of that just makes me gag. So I think my reflexes are good. Uvular deviation. So what the hell is an uvula? It's the dangly bit at the back of your throat. So if you've ever looked in the mirror and you see the little punch bag thing at the bottom, at the back of the throat, that's called your uvula. That was a question a little while ago on, what was it called? It's that show where you have to get a 0 score. I can't remember what the name of the show is, but I was like, yes, I know that one. So where does it come out? This nerve, number 9, comes out of the jugular foramen. So we're going to have a look at that first and where it comes out. Here we go. So we've explored all this area of the skull already. So this is the kind of base of the skull where the brain sits. We've had a look around here. This is where all of the first cranial nerves come through, the olfactory, then all of the eye ones, oculomotor, the optic, all came through here. Then we had trigeminal around this area here. And remember, the further forward, pointless, that's it. Thank you, Stevie. The further forward you are, then the more anterior on the brain or the brainstem. That's what the nerves are labelled in that way. The first ones are at the front, and then the last ones are at the back. Because we're on number 9, we're pretty close to the back now. There was the internal auditory meatus, which was around here. So that's where your vestibulocochlear nerve went through. And if you remember with that one, it split. There was a section for one bit of the nerve and a section for another bit of the nerve. The jugular vein, but you've probably, probably heard of that one, and that descends from that same hole. We've got, it is quite a large opening in the base of the skull, and then we've got this one here, the foramen magnum. So you've got a big hole, basically, where the spinal cord comes through. The cord is coming through this bit, and then we've got a branch coming off, so it's got to be pretty close to the back, because that is right at the back of the skull. You've got 3 nerves that pass through this foramen, and we're going to hopefully get through 2 of them today. This is your glossopharyngeal. This is the tube map. We've had a look at all of the others, and if we have a look here, we've got anterior compartment of jugular foramen. That's where it's coming through. The nerve will pass through that foramen, and then one of the nerves comes straight back up again and goes into the dura of the back of the skull. Not worried about that one today, but these are the ones we're interested in. We had a greater petrosal nerve last time. This is the lesser petrosal, and we've got a supply over to the parotid gland. This is one of the parasympathetic parts of this nerve, of this particular nerve. It produces saliva, another nerve to help with saliva production. There's also motor control to help with swallowing, which is one of these muscles just here. This is the stylopharyngeus muscle, which aids in swallowing. It attaches to the pharynx, and when it contracts, if you feel your neck as you swallow, that muscle will be helping with that swallowing action. Some of the things we can ask about is, are people like choking on their food? Do they struggle swallowing their food? Do they struggle when they're drinking water? But if they haven't put 2 and 2 together, then maybe just watch them as they drink a glass of water. We've got tonsils, a sensation from there. We've got pharyngeal, sensation to the back of the throat, a taste on the back of the tongue. But really interestingly, what this nerve does is it also helps to regulate your blood pressure. Really, really interesting. What this does is it wraps around something, a thickening on the internal carotid artery. It goes from common carotid into internal carotid. It's the same vessel. But there's a thickening, and this nerve wraps around that thickening, and what it does is it measures the pressure of your blood pressure in that area. That's what this nerve does, which is good. We've got a mixed nerve, sensory taste buds, proprioception for swallowing, monitors blood pressure in the carotid sinus, and if you've heard of a barometer measures weather pressure, baroreceptors measure pressure in your body. That's what this does. It monitors O2 and CO2 in the blood via chemoreceptors, so chemical receptors, in the carotid bodies which are near the arch of the aorta. And then in the ear, we've got sensation of heat around the ear, but motor for swallowing and parasympathetic for salivary glands. There's quite a few jobs that this little nerve does. It's quite a useful little nerve here. If we have a look here, we've got a couple of different branches that come off, but as you can see, this is a lot lower this time than some of the other ones that we've had a look at, because they've been supplying really the top of the head. The trigeminal is probably one of the ones that is a little bit different to all the others that we've seen. They've been mostly located up here. Facial, trigeminal has ventured down this area here and into the neck. This one, because of where it's located, is more this kind of region here, sort of middle of the face, glossopharyngeal. Had a couple of questions about this before. So we got the old Vulcan death grip, and if there's that's an incorrect spelling there, sorry about that. So swelling or dilation of the common carotid artery and the internal carotid artery, they're the same artery but just given different names. Carotid sinus hypersensitivity or pressure on the carotid sinus can cause syncope, which is a sudden drop in blood pressure which will cause you to faint. If there are problems with this nerve, then it will cause dysphagia, difficulty swallowing. If the muscles that activate the movement of the pharynx don't work properly, then you're going to struggle to swallow. Reduction in saliva, loss of sensation in the throat, yeah. So you basically have a dry mouth. If you like a bit of dryness in the mouth, that's one of the questions that you can put on your form. And then loss of taste, and then the pharyngeal gag reflex, okay, which is that tongue depressor one that I was talking about before. But obviously I don't use these terms on my form. I just put dry mouth and loss of taste, but those are the posh terms for those. Cool, right, let's have a look at that. Glossopharyngeal, there it is, here we go. Just a quick recap of what the glossopharyngeal does. Just going to move me over here, I think. What we've got, if I just pause that there, the cerebellum has been removed from this brain. So we're looking at the back of the skull. And we've got some things that we saw last time, where the vestibulocochlear nerve comes up here. Yeah, and then we've got these nerves coming along here. I don't know whether you guys can see them. It's a bit dark on my screen. But we've got 9, 10 and 11 all together. And they're all going through that jugular foramen, which is what we looked at earlier. We've got glossopharyngeal, which is what we're looking at now. Then you've got the vagus, and you'll see that there's a big difference between those two. And then this one here, which is the spinal accessory, sometimes just called accessory, but really spinal accessory nerve. We've got 9, 10 and 11 all going through that jugular foramen. Yeah, good question. Yeah, so you'll likely fainting, syncope basically, where you have what we call drop attacks. I don't know whether you remember, like way back at the beginning when we looked at the cranial nerves at the start, we talked about the 5 Ds and 3 Ns. Some of the Ds were drop attacks, dysphagia, diplopia, so double vision. What else was there? Dizziness. That's where these all come from. If you have drop attacks, so fainting, unexplained fainting, there may be a problem with that glossopharyngeal nerve. And nystagmus as well was one of the nystagmus, nausea. We're focusing on this one just here, nerve number 9. Let's have a look at where that one goes. Hopefully. Is it playing? Yeah, there we go. 9 and 10 together. 10 is really quite broad, but we'll have a look at that in a bit more detail. There's the one we're interested in. There's number 9, the glossopharyngeal. If I just pause that there. Yeah, 9 is just there. Underneath it, can you see this like band? There's like a flat band of nerves all coming off of the medulla just here, and all of that is number 10. Okay, that's your vagus nerve, and it's massive, the vagus nerve. We'll have a look at that in a sec. But the one for now is this one here. It's quite a small glossopharyngeal. That is coming out. Just grab my skull. Let's see if you can see. Get my finger in the right direction there. It's coming out there, right at the back of the skull. There's your foramen magnum, where your spinal cord will go, and then there's the jugular foramen just there. That's where that's going through. So there's your vagus, all of that area there. We'll have a look at that in a second, but it covers all that region just there. And then this one's your spinal accessory at the bottom, but you can see that they all feed through into that jugular foramen just up there. And the spinal accessory comes quite low down. It actually goes through the foramen magnum, so it's really low. Let me just go back on. Just pause that when that picture comes up. Move me out of the way. I'm going to pause that. Hopefully get it in the right place. There we go, cool. And then there's your jugular foramen. This is how it maps up to the schematic. On the schematic, we're just looking at one nerve, but we've got several pieces of that one nerve, and they all do different things. You've got like a parasympathetic branch, we've got a motor branch, which then splits, and then we've got a sensory branch as well. But they all come through here, and that's the jugular foramen, and that's the jugular foramen. All of these branches here are from that one nerve just there. You can see where it goes to. And then there's your jugular foramen. That's it on the video. There's your foramen magnum, where the spinal cord will go. And this is it on my model at home. There's your foramen magnum, and there's your jugular foramen just there. You can see it's quite a wide hole. If you think about all the ones that we've had a look at before, they've been fairly tiny. This one has got a lot of stuff going on. It's a bit of a gateway for a few structures going through there. That's your jugular foramen. Just move me back over there a sec. And then if we spin it around, you can see where it's going to come through. And it's just up in there. If I just pause that there. So what have we got? Behind where I've written jugular foramen there, that'll be your mastoid. And then you can just see the tooth part of the styloid coming through as well. There's that pointy bit where your styloid muscles will attach onto. There we go, I can see that there. 9, 10 and 12 all emerge through that point. There's another little hole there where another nerve will come through. But for now, we'll concentrate on that bit just there. You'll notice that there's that kidney bean shape, that's where the nerves come through, and there's a gap at the back. That's where the blood vessels will pass through. This is what it looks like in the wet cadaver. We've got 4 cranial nerves all there. There's your mastoid, that's your ear roll, the external auditory meatus, and then that blue vessel there, or blue coloured vessel, that's your jugular vein. There is another vessel just underneath it. See that one there? That's your carotid artery just there. These nerves are literally like in that section there of your neck, right at the side. We're going to try and separate these out and just do one at a time. Yeah, there's your internal carotid artery, and that's where your carotid sinus will be. The styloid process would be there, okay, but they've removed it. And then there's your glossopharyngeal nerve just there. The styloid's been removed, and then all the muscles that attach to it, they've been removed, so you can see underneath. It's deep in your neck. Posterior digastric's been removed. So that's one of the ones that supplies the floor of the mouth, or activates muscles in the floor of the mouth. And then there's your glossopharyngeal nerve just there. A tiny little nerve. If I just going to pause that there in a second. It runs through, there we go. And what it does, I don't know whether you can see, but can you see that muscle just there? That's your stylopharyngeus muscle. So it attaches onto the styloid and then down to the pharynx. What it will do when it contracts is it will pull the pharynx upwards, so that creates that swallowing action. That's one of the things that the glossopharyngeal will do. So there's your stylopharyngeus muscle, and then if I'll pause this in the right section just here. Here we go. We've got muscles in the side of the jaw as well, and they're called constrictor muscles. We've got a superior pharyngeal constrictor just here, and then a middle pharyngeal constrictor, which is just there. You can see it attaching to the hyoid bone, and there's a bit of a gap in between the two. And that is where, so that the nerve number 9, the glossopharyngeal, you can see it, and then it just disappears. It's passing in between those two muscles to get to the pharynx. That's its pathway through. And then there's your pharynx behind there. There we go. And then we've got supply to the back of the throat. Just move me out of the way again. Sensation to the back of the tongue, sensation to the back of the tongue. That's this part here, one of the branches that's come down. But for it to get through to there, it's had to go through those constrictor muscles. It's gone right to the back of the throat. That's how it passes through. Back of the tongue, back of the throat, the pharyngeal area, and that's it. Okay, so that is your glossopharyngeal nerve. Cool. Right, I just missed a question there. So in martial arts, Steve has asked, a strike to the neck, is it the carotid artery or this nerve or both? It could be both. Depends where. Yeah, I guess it depends on how hard you hit, because it's quite deep, the nerve. But if you put pressure onto that carotid sinus, then it will just knock you out. Yeah, so it's more likely to be that. There was, I did a bit of research on this last night, actually, just reading up about martial arts and stuff, and using these kind of pressure points in the body to create an advantage. And there was talk about like karate chopping sort of to the neck region, but I think that's more of a brachial plexus injury, like a stinger, the kind of thing that you would get in rugby. I had the same deadlifting once. I was deadlifting pretty heavy, and I didn't set up my arms right, and I just dropped my shoulders down, and it just pulled on my brachial plexus, and my arm went dead. So I think that things like that affecting the arm, or obviously brachial plexus stuff, but yeah, if it knocks you out from a hit here, then, or around that region, then it's probably carotid sinus. Yeah, I shouldn't be giving you these tips, should I? We did get time. We're going to introduce the vagus nerve. This is a massive nerve, but anatomically it's actually quite simple. It's nerve number 10. Its exit point is the jugular foramen, so same as what we saw before, obviously called the vagus nerve. Is it sensory, motor, or both? It's both. And we've got all of the same kind of functions that the glossopharyngeal had. It's sensory, motor, and parasympathetic. What does it do? It helps with taste, heart rate, digestion, muscles of the throat. And one of the tests that you can do is uvular deviation. And we'll have a look at that probably next week. These are all the things that it does. This is the mnemonic that you need to write out. This is nerve number 10, which is biceps. The biceps is both. And that's where it goes through. It's exactly the same jugular foramen as the glossopharyngeal, which we saw in the video as well. We'll follow the vagus in a little bit more detail. There is a lot more going on with the vagus. Obviously, it is a massive nerve. It goes for miles. A vagus basically means like vagrant, means a wanderer. This is the vagrant nerve. It's going all over the place. And interestingly as well, where the glossopharyngeal kind of branched off and then went through those constrictor muscles around that internal carotid, the vagus nerve goes in between your jugular vein and the internal carotid, and then goes down into your thoracic cavity towards your heart. It goes down. But weirdly, what it does is it's got this branch here, which is the recurrent laryngeal. On the left-hand side, the vagus nerve, as it comes down, it gets kind of caught on the aorta, the arch of the aorta as it's coming across. And then, so as you grow, and your body gets bigger and bigger, similar to the phrenic nerve, because obviously the phrenic nerve when you're a baby is really small, but then as your thorax grows, that nerve gets stretched because where it attaches to your diaphragm. Same kind of thing happens with this. There is a laryngeal nerve that comes down from your neck, wraps underneath the aorta, and then comes back into the larynx. Obviously, as you grow, your organs will descend, so that nerve gets stretched. and that's the recurrent laryngeal nerve, which is this one here. So it kind of goes down into your thorax towards your heart and then loops back again and goes back up into the back of your throat. That's your larynx muscles. Yeah, we've also got esophageal muscles. We've got an auricular branch which supplies the skin around the ear. That there's sensation around the ear from the vagus nerve. Cricothyroid muscle, which is the tensor of the larynx. We've got another swallowing action with this one. What else have we got? Heart and abdomen parasympathetic. The rest and digest part of your nervous system is predominantly vagus nerve. We had the sympathetic trunk, which we did ages ago for the thorax, and now we've got the balancing of the parasympathetics from the vagus. Okay, there's a lot going on with it. What does it do? A wide distribution, like I say, it's wandering like a vagrant. A sensory skin of external ear, taste buds, epiglottis, pharynx, proprioception in the back of the throat, baroreceptors in the carotid sinus. Again, we've got another cranial nerve that is monitoring your blood pressure, and chemoreceptors in the carotid and aortic bodies. Again, analyzing the oxygen levels in your blood. Yeah, we've got two nerves that will tell your brain what is going on with your bloodstream. Really, really important. We've got motor for the pharynx, the larynx, the soft palate, swallowing, vocals and coughing. Parasympathetic for the lungs, the heart. It regulates your resting heart rate, your gastrointestinal tract, your respiratory pathways, esophagus. I'll just leave that there for you to read. Most of the large intestine increases peristalsis and gastric emptying. But has a huge, huge role in just the health of your whole body. Amazing nerve when you see it. Whenever you research vagus nerve, you'll see images like this. We can see it's just and when you see it come off the brainstem, well, you've already seen it briefly, it's huge. Compared to all of the other cranial nerves that we've seen, this one is a chunky monkey. Let's have a look at that one. Just get those videos up. Here we go. The vagus nerve. We'll do this, and that should take us up to time. That's just a recap of all the things that we've just had a look at. You can see all the little branches coming off and where they go to, what they do. And here we are again. We're in this area again, yeah, where the glossopharyngeal was. The glossopharyngeal 10 is your vagus. All of that area there, that is all vagus nerve. And you can see how broad it is. The glossopharyngeal, tiny little thing, and then all of that is vagus. That whole region there. Yeah, really, really spreads and then just narrows into the point. All of that joins together and then goes through there, through the jugular foramen. And just turn that back a little bit, just pause that at the right time. All of that area there and then converges into that point. There it is. And then see if I can pause it at the right time. There we go. Perfect. There's, ooh, nearly did it. There we go. Jugular foramen just there. If you remember where the glossopharyngeal came through, it looked very similar. Yeah, it looked as if there were loads of little branches coming through. And you can see it a bit more obviously with this one. All in there. All of that just there. And you can see all the little filaments all joining together. Can see why there's, just about to start saying, sorry, let me just get Stevie's on there. Yeah, can see why there's so much interest in this nerve. Although I get the impression that people are looking at it as a, yes. There's a lot of people selling stuff to interfere, for want of a better word, with your vagus nerve and stimulate the vagus nerve to help with anxiety, that kind of stuff. Whether the evidence supports it or not, I don't know. I think it's a bit like magnetic bracelets, to be honest. There we go. So yeah, that's where it all comes through. Is that going to go? Yeah, there we go. And then coming through that area there. Let me just see if I can press play again. There we go. Jugular foramen. Yeah, we've seen that before. The glossopharyngeal previously. And here we are. Exactly the same. the middle compartment of the jugular foramen. At the front, you're going to have the glossopharyngeal coming through, and then behind that, the vagus. That's where that's coming through there. Last few minutes on this, and then I promise you we are done. Exactly the same as previously, so we've seen this one before. The jugular foramen, that little notch there is where the hypoglossal will come through. We'll talk about that next week. There's all of your nerves coming through there, where they come through. This is the image that we saw before. All 4 of your cranial nerves just there. Oh, is the uvula the same thing as the tonsils? It's not. It's slap bang in the middle of them. I'll tell you what we'll do. Let's do that. Here's your uvula. It's that dangly bit there. Yeah, that's basically what you're looking for. If there's a problem with the nerve, there'll be an uvular deviation. Your tonsils sit around here on either side, and this sits in the middle. This is the punch bag at the back of the throat. When you say ah, tongue depressor, and have a look at the back of the throat. If you think that there's a problem with the glossopharyngeal or vagus, then you will get a deviation of that uvula. That's what the uvula is, that bit just there. Cool. And I think that's a good place to finish.